Good morning. My name is Dr. Mario Awadallah. I'm a VGY3 radiology resident in Miri Hospital. And today I'm honored to be presenting to you a very interesting and I believe a very, very rare case that came to our ER a few months ago. Our case for today is a 30-year-old female patient, gravided 2, bar 2 through normal vaginal delivery. She came complaining of acute lower abdominal pain. She hasn't had any bowel movements since the pain began, to mark this point. And she also reports that these attacks had been recurrent for the past several months. On examination, our patient had mild lower abdominal tenderness. She had an empty rectal vault, and please mark the empty rectal vault with me. We're gonna need it. Her vital signs were stable and her pregnancy test was negative. And since she's a female of childbearing age, it was essential that we proceed with a transvaginal ultrasound exam as a beginning, at least. On transvaginal ultrasound, this was the morphology of her left ovary. Her left ovary showed an anechoic cyst, and the surrounding ovarian stroma were seen echogenic, bulky, with no detected vascularity on color Doppler, and since we rushed into the diagnosis of a left ovarian torsion. But so far, does this diagnosis seem enough? Does a patient who presents with an empty rectal vault on examination and absolute constipation as a symptom would be satisfying to diagnose it with just a left ovarian torsion? I remember clearly on that day the surgery department was very content with that diagnosis because it just meant that they would refer the patient to the obstetrics and get rid of an extra bed they had. But we insisted that at least the patient should go for a non-contrast CT scan. And this highlights that us as a radiologist, we should always have a clinical sense in these cases. Let's see what the non-contrast CT scan showed us. Let's have a detailed look at something that you might have missed. First of all, we can see over here, this is the left ovary. It is seen in the midline. Let's roll to another point. Can you see this? This is the whirlpool sign of the ovary, but it wasn't just involving the ovary. It had another organ with it. This is the sigmoid colon. The patient had a concomitant sigmoid volvulus with her. It was a case of two pathologies from two different organ systems in one patient. Let's have a look at the coronal sections. Let's have a detailed look at the coronal sections. Over here you can see the left ovary, seen in the midline, but next to it there is the famous coffee bean sign of the sigmoid volvulus, and over here we can see the whirlpool sign. The most interesting thing is that the whirlpool sign of the ovary was the same as that of the sigmoid volvulus. So I kept having the deduction that they are both rotated over each other. And I remember when we told the surgery department that we highly suspected that the two organs are rotated together and they are not just next to each other by chance, they kept saying, we've never heard of it. We've never seen a case in our life that had the two pathologies together. We see hundreds or thousands of ovarian torsions, thousands of sigmoid volvulus patients. We never had the same patients together. Maybe it's just a coincidence. Maybe they're both we see hundreds of those, maybe just one patient got both pathologies by mere chance, and that they are not torted altogether. Maybe I'm just delusional, maybe they're right. Usually our disputes with the surgery department in the ER are solved by just one method, that the patient undergoes an operation, and during the operation we see which one of us was right. But this patient didn't undergo surgery. This patient had another treatment waiting for her since she was presenting with an acute onset and she had no signs of peritonitis or bowel perforation or bowel ischemia. They decided to go at least give her a trial of a rectal tube reduction of her sigmoid volvulus. The original plan was that let's reduce the sigmoid colon and we just remain with a left ovarian torsion so that we can easily refer the patient to the obstetrics department and get rid of an extra bed. That's the master plan. Let's see what happened after the rectal tube insertion. This is the rectal tubes through the sigmoid colon. Let's have a look at the coronal sections. It's not working, but it's not majorly important. I wanted to highlight something, by the way. As you can see, there are fewer artifacts in the CT. This is because this study was taken last summer, during which we were really overloaded. The devices were getting overheated, which produced lots of artifacts in the studies. And this is what my colleague, Dr. Mohammed Osama, was just saying. But to sum up our case, this is what happened after the rectal tube was inserted. Not only that the sigmoid colon was reduced, but the left ovarian torsion was also reduced. This marks probably the first case ever in history where you could hear someone saying, we reduced the left ovary with the rectal tube. What does the rectal tube have to do with the left ovary? I was actually pretty obsessed with that case back then. I went home, I did a literature review, actually a Prisma Guide literature review through Scopus and PubMed using the keywords ovarian torsion and sigmoid volvulus. I wanted to see if there are more cases like this that ever occurred through the history. I found only 2 reported cases throughout the entire literature. Firstly was Ben Ismail et al. In 2020. They reported a very, very similar case. Here we can see the sigmoid colon, which showed volvulus, and also the left ovary was seen in the midline showing a simple cyst, and they were both having the same whirlpool sign. This was confirmed throughout surgery. The patient underwent surgery. Here we can see that the sigmoid colon was already necrotic and gangrenous, and they had to actually resect it. But the interesting thing is that they found that the whirlpool of both organs were the same one. There was only another case as well, Mevada et al. In also 2020. This time the left ovary was having a dermoid cyst, which acted as the leading point for the torsion, and there was also a sigmoid volvulus in this case. But it was also confirmed through surgery, but here it was better presented, so they could save the bowel. The bowel wasn't gangrenous in this patient. But our case was different. Our case is the first ever that gets reduced only through a non-invasive method by merely just insertion of a rectal tube. It highlights that we need to have a clinical sense. Maybe whenever we see a left ovarian torsion, just ask the patient, did you previously have any abnormalities in your bowel movements? Maybe ask the surgeon to just do a PR. Maybe check for an empty rectal vault. And that's our take-home message, and thank you.